Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 498 of our pharmacotherapy series, which majors in acute kidney injury. The next case reads, KTC, a 25-year-old male with a past medical history of schizophrenia, was seen in an outpatient clinic 4 days prior to admission, where he was started on oral acyclovir 800 mg 5 times a day for a diagnosis of herpes zoster. He presents to the emergency department complaining of sharp flank pain, gross hematuria, and dysuria. Serum chemistries are ordered and are significant only for ABUN of 34 mg per deciliter and a serum creatinine of 1.5 mg per deciliter, which are up from his baseline values of 7 and 0.9 mg per deciliter, respectively. A urine sample was obtained and visualized with microscopy. Birefringent needle-shaped crystals were seen on polarizing light microscopy. It was consistent with acyclovir-induced nephropathy. On questioning, he admits that he has not been drinking much fluid during the past week owing to a busy work schedule, and his urine volume has been markedly lower than usual. My first question to you reads, which drugs can crystallize in the urine and cause acute kidney injury? Many commonly prescribed drugs are insoluble in urine and crystallize in the distal tubule. Risk factors that predispose patients to crystalluria include severe volume contraction, underlying renal dysfunction, or acidotic or alkalotic urinary pH. In conditions of renal hypoperfusion, high concentrations of drug become stagnant in the tubule lumen. Drugs that are weak acids, e.g., methotrexate, sulfonamide antibiotics, precipitate in acidic urine. Drugs that are weak bases, e.g., ciprofloxacin, indinavir, and other protease inhibitors, precipitate in alkaline urine. Patients with drug-related crystal-induced acute kidney injury are usually asymptomatic, and kidney injury is detected by an increased serum creatinine. Occasionally, like KTC, patients present within 1 to 7 days after initiation of the offending drug with renal colic symptoms such as flank or abdominal pain, nausea, or vomiting. Urinalysis often reveals hematuria, pyuria, and crystalluria. The diagnosis is suggested by the appearance of crystals in the urine, the morphology of which depends upon the specific causative drug. Prevention of crystal-induced acute kidney injury is targeted at dosage adjustment for patients with underlying renal dysfunction, volume expansion to increase urinary output, and urine alkalization to enhance renal elimination of drugs that are weak acids, or urine acidification to enhance renal elimination of drugs that are weak bases. Dialysis may be necessary in a small percentage of patients. With appropriate pharmacotherapy, crystal-induced acute kidney injury is usually reversible without long-term complications. The next case reads, JWW is a 75-year-old Native American man, with a height of 6 feet, 2 inches and a weight of 200 pounds, who presents to the emergency room with shortness of breath and progressive worsening edema in both lower extremities. His medical history includes nephrotic syndrome secondary to diabetic nephrosclerosis, type 1 diabetes, hypertension, and chronic obstructive pulmonary disease. His surgical history includes a right-sided nephrectomy many years ago. His chronic medications are furosemide 80 mg orally twice a day, metolazine 10 mg orally once a day, lisinopril 5 mg orally once a day, diltiazem extended release 120 mg orally once a day, albuterol, inhaler as needed, and subcutaneous 20 units insulin glargine at bedtime, and insulin aspart before meals. Vital signs are temperature 36.3 degrees Celsius, pulse 77 beats per minute, respirations 16 breaths per minute, and blood pressure 179 systolic 86 diastolic. Physical examination reveals periorbital edema, jugular venous distension at a 45-degree angle to the jaw, dullness to percussion halfway up the lungs bilaterally, and 4+ pitting edema in the extremities. Admitting laboratory tests reveal the following: serum sodium levels of 140 milliequivalents per liter. Serum potassium levels of 5.5 milliequivalents per liter. Serum chloride levels of 103 milliequivalents per liter. Serum bicarbonate levels of 19 milliequivalents per liter. Glucose of 249 mg per deciliter. ABUN of 67 mg per deciliter. Serum creatinine of 5.2 mg per deciliter. Serum albumin of 2 grams per deciliter. A spot urine albumin to creatinine ratio of 350 mg per gram. Baseline renal function tests 1 month ago, a BUN of 45 mg per deciliter and serum creatinine of 3 mg per deciliter. JWW is oliguric with a urine output of 10 ml per hour. The nephrologist wants to use supportive management of acute kidney injury by first optimizing diuretic therapy. If no increase in urine output occurs during the next several hours, then the patient will undergo renal replacement therapy. So my question to you reads: what is the supportive management of acute kidney injury? Despite years of study, no pharmacologic cure for acute kidney injury exists. Supportive management is therefore directed at preventing its morbidity and mortality. This is achieved by close patient monitoring, strict fluid, electrolyte, and nutritional management, treatment of life-threatening conditions such as pulmonary edema, hyperkalemia, and metabolic acidosis, avoidance of nephrotoxic drugs, and the initiation of dialysis or continuous renal replacement therapy. An assessment of volume status should be performed in all patients who present with acute kidney injury, since correction of volume depletion or volume overload may reverse or ameliorate acute kidney injury. The underlying cause dictates management of acute kidney injury. Treating the underlying cause is of extremely important. For example, prerenal acute kidney injury because of volume-depleted states, such as septic shock, requires administration of fluids and vasopressors to restore renal perfusion and increase urine output. On the other hand, Diuretic administration for preload reduction to increase cardiac output would be required for prerenal acute kidney injury because of volume overload states as in congestive heart failure. As discussed earlier, diuretics currently have no role in preventing acute kidney injury progression or reducing mortality, but they can prevent complications, such as pulmonary edema. For edema, intravenous furosemide, e.g., 80 to 120 mg, is preferred because of its potency and pulmonary vasodilation properties. Oral furosemide therapy should be avoided because gut edema may limit its bioavailability. Torsemide and bumetanide are two other loop diuretics that have excellent oral bioavailability and are unaffected by gut edema. The dosage of diuretic needed is highly patient-specific, especially in those with frank proteinuria, glomerulonephritis, or the nephrotic syndrome. Low serum albumin limits drug transport to the kidneys and thus limits diuretic effectiveness. In addition, furosemide is highly protein-bound, and thus binds to filtered protein, which negates its pharmacologic effect on the kidneys. Combinations of loop and thiazide diuretics may be needed in patients with acute kidney injury if they become diuretic resistant. This combination acts synergistically to block sodium and water reabsorption in both Henle's loop and the distal convoluted tubule. Other alternatives include continuous loop diuretic infusions, such as furosemide 1 mg per kilogram per hour. The infusion rate should not exceed 4 mg per minute, because these rates are associated with ototoxicity, especially when given in combination with aminoglycoside antibiotics. Close monitoring of serum bicarbonate, potassium, magnesium, and calcium is necessary when giving large doses of loop diuretics. Diuresis should aim for a weight loss of 0.5 to 1 kg per day. If diuretics fail to achieve the desired fluid overload reduction, dialysis or continuous renal replacement therapy can be considered. Hyperkalemia commonly occurs in patients with acute kidney injury because the kidneys regulate potassium homeostasis. It can be life-threatening. It is prevalent in oliguric patients who are catabolic or have evidence of active cellular breakdown, such as rhabdomyolysis and tumor lysis syndrome. JWW is mildly hyperkalemic, but his serum potassium may decrease after furosemide therapy. In cases of severe hyperkalemia in which conventional pharmacologic treatment is not feasible, or not working, emergency hemodialysis should be performed. Medications that can cause hyperkalemia such as angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, or trimethoprim should be avoided. Metabolic acidosis is a common manifestation of acute kidney injury because the kidneys are responsible for excreting organic acids. Other factors also contribute to severe acidosis among patients with acute kidney injury, who are often critically ill. For example, patients with acute kidney injury because of septic shock, trauma, and multi-organ failure often have increased production of lactic acid or keto acids. JWW's serum bicarbonate concentration reveals slight acidemia that does not require correction at this time. Commonly used treatments for metabolic acidosis include bicarbonate administration and dialysis. Bicarbonate therapy may be administered as first corrective therapy in non-life-threatening and non-fluid overloaded metabolic acidosis. Severe metabolic acidosis, pH below 7.1, in the presence of anuria or oliguria and a fluid overload state should be corrected with dialysis, since worsening volume overload can occur with the administration of sodium bicarbonate therapy. Uremia can interfere with platelet aggregation resulting in hemorrhagic diathesis. Uremic patients display increased bleeding sensitivity to aspirin compared to normal patients taking aspirin. Patients with uremia and major hemorrhagic bleed may benefit from using desmopressin, also called DDAVP, 0.3 microgram per kilogram intravenously or subcutaneously for 1 or 2 doses. Desmopressin produces a dose-related increase in von Willebrand factor 7 and TPA levels. This shortens activated antithromboplastin time, abbreviated as a PTT, as well as bleeding time. The improvement in bleeding time typically begins within about 1 hour to 4 to 8 hours. Tachyphylaxis typically develops after the second dose. Other modalities that can improve platelet function and reduce bleeding in an acute kidney injury patient include dialysis, conjugated estrogens, and cryoprecipitate. Clinicians should closely monitor the patient's vital signs, e.g., weight, temperature, blood pressure, pulse, and respirations, several times per day. The patient's volume status should be assessed daily, and all fluids should be adjusted based on laboratory chemistries to detect fluid and electrolyte abnormalities, urine output, and gastrointestinal and insensible losses. Pharmacists should pay attention to nutritional support for patients with acute kidney injury to provide adequate amounts of energy, protein, and nutrients, while being sensitive to the electrolytes, acidosis, and volume balance issues. The patient's medication profile should be reviewed daily to assess for appropriate dosage adjustment in renal dysfunction. Because estimation of creatinine clearance is difficult in patients with changing renal function, therapeutic drug monitoring should be performed when using drugs with narrow therapeutic indices. When possible, nephrotoxic drugs should be avoided, but this may be difficult in patients who are septic or hypotensive and require nephrotoxic antibiotics and vasopressors. Preventive measures to reduce the likelihood of acute kidney injury should be used, such as monitoring volume status to ensure adequate renal perfusion, using dosing strategies or products that are associated with less nephrotoxicity, and avoiding drug therapy combinations that enhance nephrotoxicity, e.g., non-steroidal anti-inflammatory drug, or aminoglycosides. The next question reads, are there ways to calculate drug removal in extracorporeal continuous renal replacement therapy modalities? Recent reviews provide an excellent background on dosing drugs in patients receiving continuous renal replacement therapy. The principles for drug removal in hemofiltration are basically identical with those for removal in hemodialysis. Drug removal during continuous renal replacement therapy may occur by convection, diffusion, and adsorption. Convection and diffusion have the greatest influence on drug removal. Drug removal is inversely proportional to the percentage of drug that is protein-bound. If a drug is greater than 80% plasma protein-bound, little will be removed. This principle holds true for convection and diffusion. Ultrafiltration and dialysis flow rates also affect drug clearance. Because continuous renal replacement therapy uses highly permeable membranes, the molecular weight of most drugs has little impact on overall clearance. During convection, clearance of an unbound drug can be dramatic since continuous veno-venous hemofiltration can remove easily compounds with molecular weight less than 15,000 Daltons. The impact of molecular weight on drug removal during continuous veno-venous hemodialysis is greater than the impact seen during continuous veno-venous hemofiltration. Solute clearance during continuous veno-venous hemodialysis is dependent on diffusion, and given that diffusion is inversely proportional to molecular weight, the greatest impact is seen with drugs having a low molecular weight less than 500 daltons. Many drugs have low molecular weight, and hence continuous veno-venous hemodialysis can impact their removal significantly. Clearance during continuous veno-venous hemofiltration is accomplished through the process of convection. The ultrafiltrate produced is replaced either in part or completely. Clearance of unbound drugs during continuous veno-venous hemofiltration can be dramatic, and dose adjustments are required to prevent underdosing. The sieving coefficient of a drug is the non-protein bound fraction of the drug that is in plasma. Sieving coefficient ranges from 0 to 1, 0 representing no convective clearance. For example, a sieving coefficient of 0.8 means that 80% of the drug is unbound in plasma. Drug sieving coefficient can be obtained from the literature or by measuring concentrations simultaneously in the pre-filter blood and ultrafiltrate. The ratio of the ultrafiltrate concentration to plasma concentration is the sieving coefficient. Drug clearance can be calculated by multiplying the sieving coefficient by the ultrafiltration rate. For example, if a patient is receiving continuous veno-venous hemofiltration at an ultrafiltration rate of 1 liter per hour, and he or she is receiving vancomycin, which has an sieving coefficient of 0.8, 1 gram per day, the vancomycin clearance while receiving continuous veno-venous hemofiltration is 0.8 times 1000 milliliters per hour, equal to 800 milliliters per hour or 13 milliliters per minute. Calculating drug clearance is much more difficult in hemodiafiltration modalities, such as continuous veno-venous hemodiafiltration, because both convection and diffusion account for drug clearance, and it is difficult to predict drug clearance precisely. The use of sieving coefficient can be useful for small molecular weight drugs, but the accuracy declines with larger drug molecules, such as vancomycin. When possible, therapeutic drug monitoring should be performed to maintain therapeutic concentrations and to maximize drug therapy. Drug references such as Drug Prescribing in Renal Failure provide useful guidelines in a concise tabular format. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 499.